Hey everybody, welcome back to the second half of our total hip arthroplasty rehabilitation presentation. If you remember in the first half, we talked about a little bit about anatomy of the hip and then hip OA and why people get hip OA, and then how we can classify hip OA and also decide whether or not the patient's appropriate for surgery. Talked about diagnosing hip OA, and then we talked about the clinical practice guidelines from JOSPT that were originally published in 2009, and their recommendations for treatment. There was also a revision done in 2017. I don't know if this one has been translated into Chinese yet, but the recommendations for assessment were very, very good. You'll see they were level A recommendations, meaning that there's good research to show that physical performance measures as well as physical impairment measures listed here can be very helpful in tracking our patients. And then the treatment recommendations, also level A, related to performing manual therapy for 6 to 12 weeks, as well as performing flexibility, strengthening, and endurance exercises for 6 to 12 weeks as part of treatment. Surgery is indicated with certain situations like a fracture. We talked about that, avascular necrosis, and then significant OA. And we talked about the surgical techniques and the fact that in China we primarily use the posterior approach. The surgeons are going to provide a posterior approach for the surgery. And so they're going to replace the acetabulum as well as the femur, the head of the femur. And you do want to make sure you know whether or not it's a cemented versus cementless implant, because cementless implants will probably require a little more time in non-weight bearing or limited weight bearing. So this is sort of a picture of what the components look like for that hip replacement. We're not going to watch the video again. We talked a little bit about the complications related to the surgery. Again, the biggest complication is likely the postoperative dislocation. And so that's why we provide our patients after surgery with certain surgical precautions. And I would say more patients than not have been given these precautions by their doctor, but not all of your patients. Probably 60% have been told that these things are true. In terms of the precautions following surgery, you want to make sure they're not performing any flexion greater than 90 degrees at the hip, no internal rotation past 0, and no adduction past midline. If they did happen to get an anterior approach, then they recommend cautioning extension and external rotation. So the opposite of what we think of for the posterior approach. So again, most of your patients are getting a posterior approach. You need to make sure on the very first visit or before they even have surgery that they understand their precautions. No flexion past 90, no internal rotation, and no adduction past midline. So it really varies, and there's no universal agreement as to how long the patient should be keeping these precautions. I've heard anywhere from the patient should keep this precaution forever to, okay, maybe 4 weeks they should keep these precautions and then they're fine. So what we tend to recommend in China is 6 months. That tends to make most of the surgeons pretty happy. So I will tell the patient they don't have to follow these precautions forever, but try to keep them for 6 months. Honestly, in the United States, 6 weeks is a little bit more common, but again, people here tend to be more conservative, and I don't want to upset any of the surgeons out there. So as long as they're keeping these precautions for 6 months, you're probably going to make everybody happy. Pre-operative treatment is very common in the US, and there's actually a lot of research out there to show that it helps to decrease the amount of time that people need to stay in the hospital after surgery, as well as improve function. And so we really encourage a pre-operative visit or couple of visits And usually what we do is do classes. So we talked about this with the total knee replacement. We tend to do kind of group classes. They don't need to be individual, but they can be. And during this time, we're going to talk about how to perform exercises of the trunk and upper extremities. It helps to allow for better mobility after gait for using a walker and things like that. We also would like to decrease pain as much as possible in the preoperative stage. We also can educate patients on things like the type of assistive device they're going to use and how to use something like a walker or a rolling walker. And then we also want to have them continue to do some sort of aerobic conditioning before their surgery. Again, a lot of these people that you're seeing, they had a fracture, and so they're not going to get any of this preoperative education before the surgery. But if you do have that option, if it's more of an elective surgery for a hip replacement, then we would recommend that you see them at least once or twice before the surgery to educate them on what to expect and provide information about exercises and transfers and using assistive devices. Some other just little rules to consider with these patients. The biggest thing that I see that people are not expecting is that the knee strength, so especially knee extension, but knee extension and flexion strength are much more limited after a hip replacement than any issues with strength at the hip. And that's not expected. Physical therapists obviously expect the hip to require strengthening and maybe even mobility activities, but they don't look too much at the knee. And this can be a big problem because honestly, quad contraction, which we've talked about for the last 3 or 4 presentations when we talked about the knee, quad contraction is the biggest problem, even after a hip replacement. So you really want to make sure that you're spending time looking at knee extension, hamstring, and quadricep contraction. You also need to spend a lot of time working on decreasing asymmetries in movement as well as just in general weight bearing. So a lot of these people have had pain for long periods of time, if it wasn't just a fracture. And so they've learned to decrease weight bearing on that involved side. And we talked about this with the knee replacement patients. Remember that the possibility of having to get a joint replaced on the other side within 2 years is pretty significant. And so if they're having a hip replacement on the left, we want to make sure that we're training them throughout their rehab to increase their weight bearing on the left, because it's likely that their brain is telling them to decrease weight bearing, and they've been doing so for many years. And so we really do have to train them and use different things that we might have available to us to help make sure that they're weight bearing equally on both sides throughout the rehab process. Obviously, initially, that's going to be painful, but as we continue to work with them, you want the emphasis to be on that. You'll see the last statement about the hip precautions. Again, we use 6 months as a rule in China because it tends to make our surgeons happier. So just consider that at this point. It's probably pretty safe. Okay, our first phase for rehab is going to be about 4 weeks. This is our protected motion phase, protected motion phase. And so our goals during the first 4 weeks following a hip replacement are going to be preventing complications. The biggest complication we said is dislocation. DVTs or deep vein thrombosis can also be a complication, so just keep that in mind. So we want movement, but we want movement within the format that we talked about. We also want to generally just increase functional mobility as much as we can and make sure that all muscles around the hip and knee are contracting correctly. So we're reviewing those hip precautions with our patients. Very important that we do that. We also really want early mobilization. So those of you who work with surgeons, we want to make sure, if we can, that we are seeing the patient after surgery within 24 hours. the outcomes are much better if we can start moving them within 24 hours. Most surgeons, and I've even noticed this in China, most of surgeons are going to allow weight bearing as tolerated immediately. That's what we're hoping for. If there's a really complicated issue or the patient has maybe other fractures or something else going on, then I would say in those circumstances, you're not going to get to be weight bearing as tolerated. But most surgeons should be allowing weight bearing as tolerated the very first day, like again, within 24 hours. So we're hoping that that's the case for you guys. And there's a lot of good research to show that that would be the most appropriate thing to do for these patients. We kind of separate these out the first couple of days and then towards the end of their acute hospital stay. So from day 1 to 3, we're showing them transfer training. We are going to help them figure out how to get in and out of a car. In China, they tend to go to a rehab hospital immediately after their acute hospital stay, but they don't always do that. So if you're in an acute setting and you're not sure where they're going after the acute care setting, I would recommend that you teach them how to get in and out of a car, because they may have to take a taxi home. And that's going to be an important thing for them to be aware of how to do it. We recommend forward front wheel walkers for gait training. Unfortunately, in China, a lot of you guys are only seeing the standard walker, which is very frustrating because forward wheel walkers are so much more appropriate for about 80% of your patients, including your neuro patients after stroke, things like that. They're just much more efficient than a standard walker. So if you can get your hands on forward wheel walkers or front wheel walkers, Taobao actually sells just the insert of the 2 wheels to a standard walker, so you can just buy those, and I think they're definitely less than 200 yuan to get the wheels for a standard walker. So I would recommend doing that. They are much, much easier to use, and most patients, unless they have significant balance or cognitive problems, are going to be most appropriate for that. You'll see the exercises here. I'm not going to go into detail on the exercises, but these are good things to start with over the first couple of days. And then after the first couple of days, again, if they're going home, you might be seeing them for home health. That's very common in the US. The first week, we're seeing them in their home, but they might also be in a rehab setting. So you might be seeing them in a rehab setting. And if that's true, we're progressing to other types of assistive devices during this first phase. So during the first month, we're hoping that we're taking them away from the walker and onto a cane after about 3 weeks. And we're also increasing our strengthening activities and weight-bearing activities. So again, they should be weight-bearing as tolerated pretty much from the beginning. So we're hoping that's true, and we can start doing things like bridges, small squats, sit to stand, those kinds of things. If you do have access to a pool, whether or not they've been doing aquatic therapy before, it's a great thing to introduce several weeks after surgery, if possible. And so for us to progress to the second phase, again, we're hoping that they're getting past the walker and starting to use a cane by the end of 4 weeks. They also need to be able to do stairs, and this can be a step 2 gait. So as you guys have hopefully learned before, up with the good, down with the bad. We want to be teaching them stairs as early as possible for safety reasons. And I've noticed that in our rehab hospital that's not true, that the therapists are nervous about doing stairs, but really they should be able to do stairs the second or third day after surgery. And we're teaching them that because if something were to happen and they had to do stairs, we want them to know how to do them. And so again, we're teaching them to just use their uninvolved side initially, which is fine. We're hoping that by the end of 4 weeks, though, that they are doing stairs more normally, especially going upstairs. We also would like for them to be doing some sort of cardiovascular activity every day. Hopefully walking. Walking is fine, but they could do cycling or something like that. Phase 2 is our loading and strengthening phase, and we're going to basically take about 6 to 8 weeks in phase 2. So usually by week 10, maybe week 12. Again, if it was a complicated situation, we're going to be in our strengthening and loading phase. And it's during this phase that we try to normalize gait and improve balance. So depending on how their balance is, we're going to decide an assistive device. Again, that forward wheel walker might be something they're still using during this phase. And we can decide if we can progress them to a cane. They may even not need an assistive device, but we want their gait to look really, really, really good before we get rid of that assistive device. Other goals during this phase, we want them to be independent with all ADLs. So when we say 10 weeks, that's 2.5 months after surgery. Your patients, if they were in a rehab hospital, should be home. And I know that you don't always have the ability to be the people to say they should go home, but a lot of these patients are staying in rehab hospitals, I think, way too long. If we're able to kind of follow this time frame, you should be able to get the patients home before 3 months. So hopefully that's true. Hopefully we can give them an independent home exercise program that they're able to continue at home. So during the second phase, continue those hip precautions. We would really say that that's true. You can always talk to the surgeon if you have that option to find out if they can decrease their hip precautions or stop their hip precautions. But if you don't hear anything from the surgeon, stick with that 6-month time frame. We also want them to understand that they need to be walking with an assisted device until they don't have a limp, until there's no antalgia. So treatment during the second phase, we're going to progress our strengthening. We want to be doing squats and sit to stand, but we don't want to go past 90 degrees. So our squats can be a great exercise for this patient population, but keep it above 90 degrees of flexion. We also are going to be doing step ups and step downs. Again, the idea is that by the end of the phase, they're doing stairs normally as well as gait. And we want to be doing cardiovascular training. So remember, these people probably decrease their cardiovascular health towards the end of their time before surgery because of pain. And so now that the pain is decreased, we want to be getting their cardiovascular training back up to hopefully a normal level for their age. Also, balance and proprioception. This is a very, very important thing, especially for the patients who did have a hip fracture due to a fall that led to your hip replacement. But it's also just important for all of these patients because we know that they're older people who are much more likely to fall. So it's really important when you're getting your history from these patients that you're asking about fall history. Have they had a history of falls, any falls in the last year or 2 years? And if they have, then you really want to make sure that you are assessing and treating balance and proprioception. So again, this is something we can go into more detail in lab about how you do that, progressing your balance activities. So I'm not going to go into a whole lot of detail here. But what I do want to talk about are some of these functional assessment tools, specifically things like the Berg balance test. So you'll notice that the milestones to progress out of phase 2, we provide you with some very important numbers related to functional testing. The first one here is Berg balance test, and this is a really appropriate test to be using with this patient population. So once they're up and moving and they're relatively safe, then I would say you want to do the Berg balance test with them. And if their score is less than a 40, they definitely need to be using an assisted device of some kind with their mobility. We also want to make sure that they're walking without a limp. So you're spending a lot of time on gait training. Another great functional assessment test is the 6-minute walk test. And we talked about this one a little bit at the beginning of this presentation when we talked about non-operative care. Our goal is that we want them to be able to perform at least 340 meters of walking in 6 minutes. And the specifics on how to do these tests, again, we don't have time to go into that now, but we might have time during lab, but they're pretty easy to just look them up. We want them to be doing stairs, step over step, with minimal railing use. So again, that's a balance thing. That's also a strength thing. So we want them doing stairs normally. We want them to be able to squat and tolerate 90 degrees of a squat. And then we want them to be able to tolerate 60 minutes of cardiovascular activity every day. And this doesn't have to be done all at the same time, but they need to be able to perform that by the end of this period, which again is about 10 to 12 weeks. The third phase is going to go until week 16, or about 4 months. And at this point, they should be home, and hopefully you're seeing them as an outpatient. And really, they should become very independent in their activities, as well as being able to have a maintenance program put together. So this patient population, we really want to make sure that they're active and that they're excited about being active, and they continue to be active by the end of phase 3. So we're going to progress our strengthening activities with lunges, adding weights to things like lunges and squats. We're also going to progress cardiovascular training as well as balance training. So we're going to start putting them on uneven surfaces. Again, we're doing that Berg balance test. It's a great test for assessing balance, but also for providing our patients with goals. So we actually have a really cute patient right now at our hospital who did the Berg balance, and her score was like a 38. And she found out that one of the other women in her room scored like a 54. And she was like totally motivated to work on balance activities because she wanted to get her score up to the same score as one of her roommates. And so it was really cute. And I think you can use that kind of thing to motivate your patients, is using these tests to kind of help them get to a place not only that they want to go, but maybe that would be the most appropriate types of goals for them. And so just the last thing to touch on here, by the end of the third phase, we really do have other functional goals that we want them to have. So we really do want their Berg balance to be greater than a 44. Even if they are using an assisted device, we want that score up there. And that's actually not that hard. I find that people in China actually can get that score much more easily than some of our other patients in the US. So that's good. 6-minute walk test, we want them to get over 375 meters. Timed up and go is another test that we haven't really talked about, but it's a much shorter and easier functional test that you can do. They're basically just sitting in a chair, and you instruct them to stand up, walk 3 meters, turn around, and sit back down. They should be able to do that in less than 10 seconds. So again, these are all really easy measurable goals that you can play with your patient. They should be able to do stairs without a railing. They should be able to squat for a public toilet. So again, this is a situation where the doctor may say no more than 90 degrees of knee flexion. So that's going to make that goal a little bit difficult. But you do want to really be able to work on squatting so they can tolerate it to at least 90 degrees. And then continuing their cardiovascular activity for greater than 60 minutes. So you'll see that our treatment is relatively straightforward, and most of your patients are going to demonstrate really, really great outcomes after a hip replacement. I would say of everything that we see in the US as well as in China, hip replacements really do give you probably some of the best outcomes. The surgeons really know how to do that posterior approach surgery. So as long as they're following the precautions and keeping, hip flexion, less than 90 degrees and no adduction and no internal rotation, you're less likely to get a dislocation, and we're much more likely to have great outcomes. So I highly recommend you considering using some of these outcome measures that we talked about throughout this presentation to help motivate your patients, and just consider balance issues. Make sure you're working on balance with them. And again, I think you can be very happy and satisfied with how your patients do following this surgery.